Started with today's program. It is thyroid awareness. And so I've got Sara Gaul here. She's also our diabetes educator, and you have a really cool title.
Well, I used to just be a certified diabetes educator, and then they meaning like the governing body of diabetic educators, decided we do more than just teach. So it's a certified diabetes care and education specialist. Isn't that a lot of words? But yeah, I'm the diabetes educator up here.
Well, I'm going to turn it over to her, and then we're going to have a little at the end of today's presentation. We'll also kind of give you a little bit of a hospital update of things that are kind of going on, kind of where we're at with construction, and then along with new providers, new equipment. We got all kinds of crazy things coming up between now and 2027. So I'm going to turn it over to you, Sara.
All right. As Dustin said, I'm the diabetes educator up here, and you might be asking, then why are you talking about thyroid? And I asked Dustin the same thing. I am not an expert in thyroid, but I am the nurse that works with the endocrinologists who come here and do clinic from the med center. I have been their nurse for that clinic since 2015. And because endocrinologists help manage diabetes, thyroid disorders is another condition that they manage a lot. So I've had a lot of exposure to managing thyroid disorders in the last 10 plus years. So again, I'm not an expert, but I am going to share just some basic knowledge on thyroid with you today. So first of all, what is the thyroid? It's a small butterfly-shaped gland in the base of your neck. There's a middle part here called the isthmus, and then there's two lobes to your thyroid, a left and a right. And the main function of your thyroid is to manage your metabolism, okay? So if your thyroid is underactive, that's hypothyroidism. It can also be overactive, which is hyperthyroidism. And we will get into that shortly. Before we talk about that though, there's another player in the whole thyroid game, and that's our pituitary gland. This is a little gland in the base of your brain that's kind of a master gland. The pituitary gland secretes hormones to different glands in your body and to kind of tell them what to do. You have to think of the pituitary gland as kind of like the thermostat, okay? When you set a thermostat at your house, that's what keeps things in check, right? And actually your furnace and air conditioner is actually the thing kicking out the heat or the cold, right? So the pituitary gland is like the thermostat, and your thyroid gland is like the furnace or the air conditioner. The pituitary gland releases a hormone called thyroid stimulating hormone, which then tells your thyroid how much thyroid hormone it needs to make and release. Does that make sense? So there's kind of the thyroid stimulating hormone, and then down in the thyroid gland is the actual thyroid hormone. So again, we kind of talked about this. Hypothyroidism is when your metabolism is too slow. Hyperthyroidism is when it's too fast. We're going to start by talking about hypothyroidism. This is pretty common. Almost everybody probably, either if you don't have hypothyroidism, knows somebody who probably does. This happens when the thyroid does not make enough thyroid hormone. So there's several causes to hypothyroidism. One of the most common is called Hashimoto's or autoimmune thyroid disease. What happens is something causes your thyroid to kind of attack itself, and then its ability to make thyroid hormone is reduced. Not normally completely taken away, but the thyroid after that happens has a hard time producing enough thyroid hormone. Another reason that we can have hypothyroidism is surgery. Some people have to have their thyroid removed. Let's say someone had thyroid cancer and had to have their thyroid removed. That would leave them without the ability to make enough thyroid hormone. Radiation. Some people that have certain radiation for some cancers and lymphomas, you can be left with hypothyroidism because that radiation destroyed your thyroid's ability to make enough thyroid hormone. And then aging. As people get older, the rates of hypothyroidism, usually due to this autoimmune thyroid disease, go up. We see that increase as people get older, the chances of hypothyroidism. So how do you know if you could have hypothyroidism? There are a lot of very vague symptoms. So, these symptoms can mean that you have a lot of things. But thyroid is something that usually comes to mind, and it's something easy to check for. So providers, if you're going to your provider saying, I'm tired, I'm gaining weight and I can't figure out why, I'm cold all the time, I have really dry skin, my hair, I feel like I'm having hair loss, I'm constipated, I'm depressed, my heart rate's been slower than normal, or I've been having heavier irregular periods, those can all be symptoms of hypothyroidism. They can also be symptoms of a lot of other things. But if you go to your provider with these, they're most likely going to check your thyroid first, because that's a kind of an easy fix if that's the reason behind all of these symptoms. For hyperthyroidism, this happens when the thyroid makes too much thyroid hormone. Okay, it's a fast metabolism. There's three main causes of hyperthyroidism. One is called Graves' disease. That is also an autoimmune disease, but it actually goes to your thyroid and is telling it to continue to make too much thyroid hormone and release it, okay? There can also be what we call hot nodules. A lot of people can have thyroid nodules or little bumps on their thyroid. A lot of times they're benign. Sometimes there can be a hot one that's sitting there just pumping out thyroid hormone, and it shouldn't be doing that. So that can cause you to be hyperthyroid or have too much thyroid hormone. And the last one is what we call a thyroiditis. For whatever reason, your thyroid can get very inflamed, and it kind of can cause your body to dump a bunch of thyroid hormone into your system. Sometimes this goes away on its own. Sometimes it can almost burn the thyroid out, and someone can become hypothyroid after that thyroiditis clears. So, and we'll kind of get into what we can do about these next. So signs of hyperthyroidism are quite the opposite of hypo. Instead of being really tired, you can have insomnia and an inability to sleep. Weight loss instead of weight gain. Feeling hot all the time instead of feeling cold. Sometimes when people have hyperthyroidism, they almost have a fine tremor. Frequent stools instead of constipation. The feeling of anxiety, and sometimes that comes along with a fast heart rate. People can have palpitations or just have a high heart rate all the time. They feel like their heart is racing. And then light or absent periods instead of heavy. So literally it's the opposite of hypothyroidism. So how do we diagnose thyroid issues? The two starred labs are the most common, and that's a TSH and a T4. T3 is not used in diagnosis very often because it is the last lab test that would show something is abnormal. So we do see providers use T3 in some instances, but the main test to find out if you have a thyroid disorder is usually that first one, the TSH. And if that TSH level is off, then a lot of times they'll run a T4, which is the actual thyroid hormone. I'm sorry, this is like WebEx and I forgot to put that I was not available. Sorry about that. So another thing, these are generally used with hyperthyroidism. Ultrasounds can be used to see if you have any thyroid nodules. Remember, nodules can be producing thyroid hormone. So they also sometimes want to see the actual size of the thyroid to see if it's normal or enlarged. So ultrasound is a great way to look at that. An uptake and scan, that is used in hyperthyroidism, so too fast metabolism, to try to figure out why it might be hyperthyroidism. They have you swallow a very low dose radioiodine tablet or liquid, and then they scan you 4 to 6 hours later and at 24 hours. What happens is if you have Graves' disease, which is an autoimmune thyroid where it's just having your thyroid pump out too much hormone, your whole thyroid gland will light up on that test. And then they know that it's Graves' disease. If one spot on your thyroid lights up on that nuclear med scan, that tells them it's probably a hot nodule. Okay. And so that's where the excess hormone is coming from. And if it doesn't really light up, that's most likely a thyroiditis that will hopefully resolve on its own. They'll have to kind of watch and treat until that point. Does that make sense? And sometimes they also do uptake and scans if somebody will have thyroid nodules that they are wondering if they need to biopsy, you know, because is this cancerous or not? On an uptake and scan, if somebody has a nodule that doesn't light up, then they decide if they need to biopsy it. Those hot nodules are almost never cancerous. So if someone comes with a big old nodule on their thyroid and they do an uptake and scan and it's hot, it lit up, there would be no reason, no matter how large it is, that they would need to biopsy that, because a hot nodule is normally not malignant. It's not cancerous, so they don't have to do a biopsy. Does that make sense? All right. And then by physical exam, you know, providers will they'll do vital signs. They might feel a thyroid. So that also is part of the diagnostic process. So TSH, because we remember TSH is released from your pituitary gland. So TSH, when you get a screening done, there's an inverse relationship between TSH and actual thyroid hormone. So if you get your wellness screening done and your TSH is high, that actually signals that you could have hypothyroidism. Because remember that TSH is telling your body to produce thyroid hormone. So if that's high, what that's telling us is your pituitary gland is saying, come on, make more hormone, and your thyroid isn't doing it. So the TSH is high because your pituitary gland is trying to get your body to listen. On the other hand, if your thyroid is pumping out too much hormone, that pituitary gland isn't telling it to dump any because it's doing it all on its own. Does that make sense? So if you get an elevated TSH or a high one, that can signal hypothyroidism. If the TSH is low, it's hyperthyroidism. It's opposite of what you would think, okay? And your provider would know all about this and go over all of this with you. So what do we do? The great thing about thyroid disorders is that they're all pretty easily treatable. Hypothyroidism, too slow, is normally treated with a thyroid hormone that people can take daily called levothyroxine. Normally, this is a pill. It has to be taken on an empty stomach apart from all of your other pills. So usually it's taken 30 minutes before any other food or drink other than water, and apart from your other pills. The reason is if you take that with like your vitamin and your cereal in the morning, that thyroid hormone binds to iron and other elements. So it pretty much makes it ineffective. So that is why you need to take thyroid hormone separate from your other pills, because a lot of pills will bind it up and then it doesn't work. Okay. Normally it's lifelong therapy. Sometimes doses might need to be changed over time, and that's why your provider would check your TSH level, normally at least every 6 months. But generally, if you have hypothyroidism, you will need thyroid hormone for the rest of your life. And again, yep, labs are checked normally 4 to 8 weeks after initially getting started, and then usually every 6 months as long as things are going well. Now, treatment for hyperthyroidism. There's kind of 3 different options for people when you have an overactive thyroid. Number 1 is antithyroid medication. There are some medications that can actually tell your thyroid to stop producing extra thyroid hormone. It's called methimazole. And then also beta blockers like metoprolol can be used to help slow the heart rate and help some of those anxiety, high heart rate symptoms, okay? So those 2 medications can be used together to control symptoms of hyperthyroidism. Those are often used in a thyroiditis. Remember, sometimes that can kind of resolve on its own. These medications can be used until that point. They can also be used some people do well on these and they don't want to do anything permanent and they just take these for the long term. Another option, if you have Graves' disease or a hot nodule, which generally do not get better or stop, you can do a radioiodine therapy. You swallow a pill of high dose radioiodine and it actually goes and kind of kills off your thyroid. So it's going to stop that overproduction. It's about 80 to 90% successful, but on the other end, because it destroys the thyroid gland's ability to make thyroid hormone, you become hypothyroid. So then you take that levothyroxine on the, for the long term. Generally, that's a little bit easier to control than hyperthyroidism. So a lot of people will do that. They'll do the radioiodine and then just take levothyroxine to get their levels back to normal. And then some people can have surgery. You can have a thyroidectomy, although that's usually not, most people don't choose that because the radioiodine therapy is you swallow a pill once and it's very effective, and then you don't have to undergo surgery, have a scar. Because if you have surgery, you're also going to end up needing to be on the levothyroxine. Obviously, there are times that surgery would be indicated, and that would be up to an endocrinologist to kind of whether they would recommend that. Okay. So how do you screen for thyroid disease? TSH is the screening test. You can ask your provider if you've had that done, if you're not sure, or if you would be able to get that. You can always get that through one of our community wellness screenings. The TSH is a $10 add-on to just the basic wellness screening. And our next one is March 3rd and 4th from 6 to 9. You can sign up for those wellness screenings online, or you can call. This slide is not in your deck, but if you need that information, I can certainly give it to you after the presentation. So when should you see a doctor? If you've been more tired than normal, if you've had unintended weight changes, whether that be weight gain or weight loss without really trying, if you're feeling your heart race or having heart palpitations, temperature intolerance, if you feel hotter or colder than people around you, and it's been going on for a while, that would be another time. Or if you have a strong family history of thyroid disease, you want to make sure that you're being screened and that your TSH is being checked at least once a year so that they can screen for any thyroid disorders. So key takeaways, thyroid disorders are very treatable. That's the great thing. If you are having hypo or hyperthyroidism, it's easy to treat. Remember, hypo is slow, hyper is fast. It's simple testing and effective treatments. Most of the time, hypothyroidism is just managed by your primary care provider, whoever that is. They would maybe refer you on to an endocrinologist if for some reason they were having trouble getting your levels normal, or if your levels are normal and you're still having a lot of symptoms, they might refer you on to an endocrinologist. Hyperthyroidism is almost always managed by an endocrinologist. They are the ones that tend to order that uptake and scan, and that would be who you would need to talk to about if you were doing the radioiodine. Our primary care providers don't do that. So usually with hyperthyroidism, you are referred on to an endocrinologist or an endocrine surgeon. All right. Any questions on that? That's kind of thyroid 101 basics. Yes. So how is it that
in families, one could be hyper and another one could be hypo?
The interesting thing is Graves' disease and Hashimoto's are both autoimmune disorders. So depending on how your body responds to that autoimmune kind of attack is whether you're hypo or hyper. And sometimes too, thyroiditis can lead to like a Hashimoto's. It's like if you have an autoimmune thyroiditis, your body dumps all that thyroid hormone and then it's left unable to catch up, and it can kind of lead to that Hashimoto's or hypothyroidism at the end. But I can't answer exactly why one person would react one way or the other.
I have a sister who has Graves and I have Hashimoto's.
Yep. And they are both forms of autoimmune thyroid disease. So I don't know why one goes one way and one goes the other. Any other questions?
Are there alternatives to taking medications that are effective?
Not really with thyroid. Some people I know that want to avoid like synthetic hormones they kind of go to some more natural providers, and they can use like swine thyroid hormone and like from other animals. I know that our endocrinologists do not necessarily prefer that because it's not as well regulated. And kind of how people can respond is not quite as dependable as like the Synthroid or the levothyroxine that you would get from a pharmaceutical company. But no matter what, there has to be some way to replace that hormone if you're hypo, and to maybe make that stop if it's hyperthyroid. Any other questions? All right, thank you guys very much.
Thank you, Sarah.
Yeah, thank you. As promised, a hospital update. Those of you, I've noticed, there's some of you that I haven't seen in so long, like Sharon, it's so good to have you back. You too, Lonnie and Wes. These are biggest troublemaker, I tell you. But you guys have not met Jill Melby. She is the new marketing and director of
Marketing and foundation.
that foundation. And she's amazing, and I just want to make sure you guys got to meet her. It's an incredible group that we have here, Jill, so I'm just glad you get to meet them. For a hospital update, and Jill might have to chime in on a few things here because I'm not real sure about everything that's going on. So some exciting things, as you've seen, we're getting new fire doors, so trying to get around this place it's kind of a jungle sometimes. Jill's been great about letting us know which doors are gonna be open, which ones are gonna be closed. So it's been really great having that they keep sending out to us, which makes it very confusing for you guys, but thank you for, enjoying the ride there. As for new things kind of coming, the doors, I believe they start to open, I think, next month for the new clinic,
New clinic
late February. And then
That's the goal.
that's their goal anyway. And then, of course, we do have the YMCA. They're going to be opening here shortly as well. With that, to kind of get us ready for the summer, there's some things that'll be happening at the front entryway, which kind of puts a hindrance on the Bloodmobile. So the Bloodmobile will actually be out at the YMCA. So that'll actually be really nice for us to have that. But they are planning to come back afterwards. So this is just a temporary fix. What else am I missing, Jill?
Yeah, so February 6th is Wear Red Day.
So everyone wear red, take pictures, post it on our Facebook page.
And then February 10th, we have the Lunch and Learn.
Yes, we have another lunch and learn. That's gonna be with the Bloodmobile. That'll be Kathy Lowry. She is the territory representative for LifeServe Bloodmobile. And so she's actually a good one. If you didn't get to see her last summer, I really encourage you guys to come back and see her this time. This is actually she's gonna talk more about like what the benefits is to be the donor rather than the recipient, because there's a lot of health benefits that I didn't even know. So she's gonna talk a lot about that. We're gonna have some fun activities coming up at the end of February. We'll actually have kind of like a volunteer fair of all of our programs that we have. So we'll have the Patient Partners Program where you're visiting people on the floor. We'll have a station there. We'll also have a station for the transportation, the ship insurance information program. We'll have a table for them. We'll also have a PFAC table. That's the patient advisory committee that we have here in town, and just kind of see what that's all about. It's kind of how to make the hospital, that group is about how to make the hospital a little bit more easier to navigate, a little bit more, some ideas that maybe, we all work here, but sometimes we just need some ideas thrown at us that we just don't think about. So those are gonna be some of the things that are coming. An exciting thing, I know they're working on it. I'm not sure exactly the details on it, but a new MRI machine is gonna be coming. And hearing how they're gonna tear out the walls, I just kind of find that kind of cool when you can rip out walls and almost look like an explosion happened, but it really didn't. So that's what I think was kind of neat about that. So I just wanted to get you those updates. Do you have any questions on anything? On that?
We
No?
also have a behavioral health therapist and nurse practitioner that will be coming soon. We don't have a go live date, but that will be telehealth. So you would come to the clinic and then telehealth from the clinic. So that's another program area that we are also going to have soon.
And then also, I just noticed Kelly G is back here. So she is with Senior Life Solutions. They're the resource that's down at the bottom of the hill here. They You can do a lot of things, Kelly. Do you want to explain just a little bit about what you do?
Sure, it's a mental health program. So if you're having issues with anxiety, depression, or grieving, we have, similar to what Jill just said, we have a telehealth psychiatrist, but then we have an on-site mental health therapist that you can meet with and have therapy sessions with. We do group therapy with other individuals, and it's geared towards Medicare-aged patients. And we have the individual, the group, and we can do family therapies. And that's in the old physical therapy building down the hill.
Oh, and then we've had a lot of fun changes and we've added a lot to the marketing group. So as everybody remembers, we've got Brandy Rusko back there. And then we have Lily. She does a lot of like photography and she does a lot of video for us. So it's actually pretty incredible to see our social media posts go viral, hopefully, really soon, which is great. And then we have Maria. She's our community liaison. She's really helping us bridge the gap with our Latino community, with the hospital. So we've actually come up with some great ideas about trying to get things more out into the community. I was talking to Sherry Konekamp. We're gonna try and do more lunch and learns off-site, just to kind of help us get things out there. So that'll probably look forward to that. Probably more kind of like April, May, we'll try to get some out there. The library has just been a great place. Seems to be kind of a neutral territory with a lot of folks go there. We all like to read. We can use the computer. So that's really what we're trying to do going into the future. And then don't worry, we'll still have lunch and learns back here too, because we know we like a good free meal because as today, it was pretty delicious. But that is all I've got for you. Any other questions, any things you want to know that you don't know? Okay, well, I'm gonna let you guys be free. It's been a while since you guys have seen each other, so if you want to mingle, feel free to for a little bit, you sure can. And then our next presentation will be next month, so if you would like to join us for the next presentation, just hop on over to ccmhia.com and go to the About Us, and under Education and Outreach, sign up for the next Lunch and Learn. And we'll be sending out postcards and all that good information for you. So thank you guys for attending. I hope you learned a lot today.
Thanks, Dustin.